Okay, get ready to dive deep into heart failure management. And a huge thank you to London Heartbeat Z Academy in the UK for giving us this awesome research article to dig into. We're talking Advances in Management of Heart Failure, published just this year in the British Medical Journal by Paul Heidenreich and Alexander Sandhu.
Really a fantastic piece of research. It's a great overview of all the new stuff happening in heart failure care. So much has changed.
It's kind of like getting a sneak peek at a cardiology conference, but without all the boring lectures and bad coffee.
Yeah, exactly. And before we get into all the details, it's good to remember just how big a problem heart failure is. As the article states, heart failure is a major public health problem with high morbidity, mortality, and healthcare costs worldwide.
For sure. It's a huge deal, and it's becoming even more common. The authors mentioned the Global Burden of Disease study, which found that a staggering 57 million people were living with heart failure in 2019.
Yeah, 57 million. And what's interesting is that it's not just because people are living longer. The overall number of cases is going up, yeah, but the age standardized rate has actually gone down a bit.
So even though more people have it, it's not necessarily becoming more common relative to the aging population. That's surprising.
It is, yeah. The article suggests that this trend may reflect improvements in preventing and managing heart attacks, which are a major cause of heart failure, of course.
That makes sense. But this ice is concerning. The article mentions that there has been an increase in heart failure hospitalizations among young adults, those aged 18 to 45 in the U.S. That's not who you typically think of when you think about heart problems.
Right, exactly. It raises important questions about lifestyle factors, early detection, and whether prevention efforts need to be aimed at younger people.
Absolutely. And when you look at that global map of heart failure prevalence in the article, the differences are pretty striking. The highest prevalence is in high-income North American countries, and the lowest is in Central Asia.
Yeah, huge differences. Those differences likely reflect a lot of different factors, like diet, access to healthcare, and even genetics.
Yeah, for sure. It really shows just how global this problem is. Now let's talk about survival rates, which is always a tough topic, but a really important one.
Definitely. And the article is very upfront about it. The prognosis for heart failure, especially for older individuals, is not good. Median survival in the community after diagnosis is estimated at 2 to 8 years, with worse survival in older individuals and in those with multiple comorbidities.
Wow, yeah, that's tough to hear. But are there any positive trends?
Oh, absolutely. The authors point out that survival has actually improved since 2000, particularly for younger patients, which shows just how much of an impact ongoing research and new treatments are having.
It really is like a race against time, right? Trying to push medical science further to give people more life. The article also talks about years of life lost due to heart failure.
Right. This measures not just how long someone lives, but how much life they might lose because of their condition. And it's sad. Those with other health problems, what are called comorbidities, lose the most time.
That's a powerful way to think about the real impact of heart failure. The authors also mentioned the potential long-term impact of COVID-19 on heart health.
Yeah, there's a lot we don't know yet. But they do mention some studies, which show an increased risk of things like heart failure, even after people recover from COVID-19.
So we're still learning about how COVID will affect us long term. Well, let's switch to something more hopeful. Prevention. The article reminds us that heart failure is often preventable, especially if you manage the main risk factors.
That's right. The article says, control of risk factors such as uncontrolled hypertension, diabetes, and chronic kidney disease is essential. And it's not just about avoiding heart failure, it's about staying healthy in general.
Definitely. And the article actually goes beyond the typical advice. It talks about some specific medications, like SGLT2 inhibitors and finerenone, which have shown promise in reducing heart failure risk, especially for those with diabetes or kidney disease.
Yeah, they're game changers.
And this is where it gets really interesting. The article highlights a study called SOP-AGF, where they screened patients for high BNP levels, which can be a sign of heart problems.
Oh, wow.
And those with high levels got more testing and proactive care.
Interesting.
And get this, this approach led to a decrease in new cases of heart failure and fewer emergency hospital admissions.
That's impressive.
It shows just how important early detection is. But what happens when heart failure does develop? How do doctors even figure out that it's happening? The article takes us through the diagnostic process, which honestly sounds kind of like detective work.
It kind of is, yeah. The first clues are usually the patient's symptoms: shortness of breath, fatigue, swelling in the legs or ankles. These are all signs that the heart isn't pumping as well as it should.
And then there's that key test that measures left ventricular ejection fraction, or LVEF. It tells us how well the heart's main pumping chamber is working. And based on LVEF, the article says that heart failure is divided into 3 types.
Right. You have heart failure with reduced ejection fraction, or HFrEF, where the heart's pumping power is significantly weakened. Then there's heart failure with mildly reduced ejection fraction, HFmREF, which means a slight decrease in pumping power. And then finally, there's heart failure with preserved ejection fraction, or HFpEF, and that one is where things get tricky.
HFpEF, yeah. How can you have heart failure if the heart's pumping strength seems normal?
That's the thing. In HFpEF, the heart's pumping strength might be okay, but the problem is in its ability to relax and fill with blood between beats, as the authors point out. Measuring these filling pressures is challenging, and no single non-invasive test is considered definitive for the diagnosis of HFpEF.
So it's like trying to solve a puzzle, but some of the pieces are missing.
Pretty much. Doctors use scoring systems a lot, which combine results from several tests and clinical observations to figure out how likely HFpEF is.
It sounds like a complicated process, but what happens once they do make a diagnosis, especially for HFrEF? The article talks about a bunch of medications that can really be lifesavers.
Oh, yeah. These are what the article calls the 4 pillars of HFrEF therapy. Each one targets a different part of the condition.
Okay, let's hear about these pillars. First up is ARNI, which stands for angiotensin receptor neprilysin inhibitor.
That's right. It's a combination medication. It blocks the hormones that can make heart failure worse. And at the same time, it boosts those enzymes that help the heart relax and work better.
Sounds pretty powerful.
It is. The Paradigm-HF trial, for example, that was a huge study, showed that the ARNI sacubitril valsartan significantly reduced the risk of death or hospitalization from heart failure compared to the standard treatment with an ACE inhibitor.
Wow. But the article also mentions the Pioneer-HF trial, which looked at people hospitalized with heart failure. What did that show?
So Pioneer-HF showed that starting sacubitril valsartan early, even during a hospital stay, led to significant improvements in how severe the heart failure was. Basically, it means getting on the right medication quickly can really help you recover.
That's really good to know. But is ARNI helpful for anyone with HFrEF?
Unfortunately not. Studies show that ARNI isn't helpful for people with really advanced heart failure. Those with very severe symptoms who need continuous IV meds, it's shown that treatments need to be tailored to each person.
So ARNI is a powerful tool, but not a cure-all. Okay, what's the next pillar of HFrEF therapy?
Next up is a really interesting class of drugs. SGLT2 inhibitors, we talked about them earlier for prevention. They were originally developed for diabetes.
Ah, right. So they're useful for 2 things.
They are, and they work really well. The article shows that SGLT2 inhibitors consistently reduce hospital admissions due to heart failure, and in some cases, they even reduce cardiovascular deaths.
So not only are they keeping people out of the hospital, but they're also helping people live longer. That's amazing. Are there any specific SGLT2 inhibitors the article mentions?
Yes, they talk about sotagliflozin, which is special because it blocks both SGLT1 and SGLT2, so it might have even more benefits. 2 trials, Soloist, WHF, and SCORED, showed that sotagliflozin is effective for people with both diabetes and heart failure, even if they also have kidney problems.
Yeah, so it's like a triple threat. Diabetes, kidney disease, and heart failure.
Yeah, it's pretty impressive. The evidence is so strong that it's now included in the European guidelines for heart failure. Though, funnily enough, it wasn't included in the U.S. guidelines because it was only just recently approved here.
It just goes to show that things are constantly changing in medicine.
Absolutely. And speaking of things changing, we've made a revolutionary discovery about how to treat HFrEF, and that's how important it is to start medications quickly and get to the right dose quickly.
Okay, this is where it gets really exciting. We're not just talking about what medications to use, but how to use them in the best way possible.
Exactly. The STRONG-HF trial, which the article talks about in depth, showed that increasing the doses of these life-saving medications quickly really improved patient outcomes.
How much of an improvement are we talking about?
Okay, so they found an 8.1% reduction in readmissions or death within 180 days for patients who had their meds increased rapidly compared to those on the standard schedule.
That's huge. It shows that acting quickly can make a real difference.
It does. And this idea of starting quickly was also seen in other trials, like DAPA-HF and Soloist.
So speed is key in HFrEF treatment. But this brings up a question. How do we get people on all 4 drug classes quickly and do those safely?
That's the million-dollar question. The article talks about 2 main strategies, the sequential approach and the all-at-once method. The sequential one starts with SGLT2 inhibitors and MRAs, and then slowly adds the other medications one at a time. The all-at-once approach gives all 4 drugs together right away, but at lower doses to start. Then those doses are increased quickly.
So it's like choosing between slow and steady versus a more aggressive approach. What are the pluses and minuses of each?
Well, the sequential approach is probably gentler as far as side effects go, because patients have time to adjust to each medication. The all-at-once approach gets all the medications on board quickly, but it needs to be monitored closely to manage any side effects.
Sounds like a tough balancing act, trying to maximize the benefits and minimize the risks.
Exactly. The best choice depends on the patient, their condition, other medications they're taking, and their ability to handle side effects.
So it's not just about knowing the drugs, it's about using them strategically. And let's talk about diuretics. These are the medications that help get rid of excess fluid, which is common with heart failure.
Right. The article explains that diuretics are important for managing congestion and relieving symptoms, like shortness of breath and swelling. But they haven't been shown to help people live longer.
Because they make you feel better, but they don't necessarily make you live longer.
That's what we know right now. The Transform-HF trial compared furosemide and torsemide. Those are two commonly used loop diuretics, and there is no difference in death rates between the two.
Interesting. So it's not about picking the right diuretic. It's about using them in the right way to manage symptoms.
Exactly. The article also talks about some studies that combined different types of diuretics. For example, the ADVR trial. They found that adding intravenous acetazolamide to loop diuretics helped with congestion.
So it's like using different diuretics together to tackle fluid overload from different angles.
Exactly. And the chlorotic trial had similar results. They added thiazide diuretics to loop diuretics. But the article does say that while these combinations seem good for short-term decongestion, we need more research to know if they're safe in the long term.
It's like trying to find that sweet spot with fluid levels.
Yeah.
Now, I'm curious about something. What happens when someone with HFrEF starts treatment and their ejection fraction actually gets better? Does that mean they're cured?
That's a great question. And it's one that researchers are still trying to figure out. The article explains that about 15% of patients with HFrEF see their ejection fraction rise above 40% with treatment. But we don't really use the term recovered anymore. We say improved.
Why the change?
Well, a key trial called TREAD-HF showed that if you stop medication in people who seem to have recovered, almost half of them relapsed. Their hearts seemed to be working fine, but the underlying problem hadn't actually gone away.
Wow, so even when things seem good, you can't let your guard down.
Exactly. The current recommendation is to keep up the HFrEF treatment even when the ejection fraction improves. Stopping treatment is only really considered in very specific cases where the cause of the heart failure is something that can be reversed, and it's been successfully addressed.
So being cautious is key. Now let's talk about those with HFmREF and HFpEF, the folks with mildly reduced or preserved ejection fraction. What does the research say about how to treat them?
Good news. SGLT2 inhibitors work for them too. Those two big trials we talked about earlier, DELIVER and Emperor Preserved, had a lot of patients with ejection fractions above 40%. And the results showed that SGLT2 inhibitors helped across the board.
It seems like SGLT2 inhibitors are good for all types of heart failure.
They really are. But for those other HFrEF treatments, like ARNI, ACE inhibitors, ARBs, and MRAs, there's less evidence for them in HFmREF and HFpEF, so they're usually second-line choices.
Makes sense. And the article specifically says to avoid beta blockers in HFpEF.
Yes. A meta-analysis of many trials found that beta blockers didn't help people with HFpEF, and they might even make death more likely. So it's a situation where a medication that's good for some types of heart failure isn't good for this specific type.
It shows that heart failure is not one size fits all. Each type is different and needs its own treatment. But the article actually goes even further and challenges how we think about LVEF as the way to classify and treat heart failure.
Oh, interesting.
The authors point out that many drug therapies have shown benefits at higher LVEF levels, higher than that traditional 40% cutoff for reduced ejection fraction. For example, beta blockers have been shown to reduce cardiovascular death in patients with LVEF below 50%. And ARNI has shown benefit in patients with LVEF up to 60%.
So the lines are blurry.
Yeah. It's more complex than just looking at the LVEF number. Treatment needs to be personalized.
Absolutely. It's about looking at the whole picture. And speaking of personalized medicine, let's talk about some other drug treatments that can help HFrEF patients beyond those four pillars.
Okay, so even more options.
Right. And one of these options is especially important for Black patients. Hydrolase and sorbide dinitrate therapy.
I know that combination has been around for a while, but it's still important.
It is. It helps to dilate blood vessels,
Yeah.
which reduces the strain on the heart. A major trial, the AHFT trial, showed a 43% reduction in death in Black patients with HFrEF who were treated with this combination.
That's incredible. But the article also mentioned some challenges with this therapy, right?
Yes, unfortunately. Not a lot of people use it or stick with it, probably because you have to take it 3 times a day. And there are concerns about it being specific to one race. We also don't really know how well it works for non-Black patients.
So it's a good tool to have. But it's important to try those 4 pillars first, and then consider hydrolysinate as a second option for Black patients.
Exactly. And speaking of second options, another medication the article talks about is Ivabradine.
Right, that one slows down the heart rate, so the heart has more time to rest between beats.
Exactly. And the SHIFT trial showed that Ivabradine reduced the risk of cardiovascular death or hospitalization for heart failure in patients with HFrEF and a fast heart rate, even after they were already on the best beta blocker therapy.
So it's like a backup plan.
Right.
When beta blockers aren't enough to control the heart rate.
Exactly. The key is to optimize beta blockers first, and then think about Ivabradine if needed.
Got it. Start with the most proven therapies,
Mm-hmm.
and then add other options if necessary. What about some of the newer medications? The article mentioned Revascularisation, right?
Yes. Revascularisation is pretty unique. It stimulates a pathway that helps blood vessels dilate, which reduces stress on the heart. The Victoria trial showed a small but significant reduction in cardiovascular death or hospitalization for heart failure for patients with HFrEF who had recently been hospitalized or needed IV diuretics.
So it's not as powerful as the 4 pillars, but it's another option for high-risk patients who need more help.
Exactly. It's usually considered for patients who are already doing everything else right.
Okay, that makes sense. Now let's talk about something that's often overlooked, but can have a big impact on heart health: iron deficiency.
Ah, yes. The article talks about the connection between iron deficiency, anemia, and worse outcomes in HFrEF.
So it's not just about getting enough iron from food, it's about making sure your body can actually use it.
Exactly. And studies have shown that intravenous iron infusions, not just pills, can really make a difference.
So getting iron levels right could be a game changer for some people.
It can. Heavy iron has helped to reduce hospital stays and improve quality of life for people with HFrEF.
Another tool in the toolkit for heart health. Now let's talk about a class of medications we mentioned briefly before, but they have implications for more than just diabetes: GLP-1 receptor agonists, or GLP-1RAs.
Right. These were first made for diabetes, but they might also be good for the heart, especially because they can help people lose weight, which is important for heart failure since obesity is common.
Yeah, that makes sense. The STEP HFpEF trial showed that semaglutide, which is a GLP-1RA, improved how people with HFpEF and obesity felt, and how well they could exercise.
That's good to hear. But the article also mentions some concerns about using GLP-1RAs in HFrEF. They cite an analysis that showed a possible increase in heart failure hospitalizations in patients with HFrEF who were taking GLP-1RAs.
So they might be good for HFpEF, but we need more research to know if they're safe for HFrEF.
Exactly. It shows that what works for one type of heart failure might not work for another.
Now, let's get into the world of devices and interventions. These are the high-tech tools we have. When medication alone isn't enough, let's start with something that sounds pretty futuristic: a device implanted in the body that constantly monitors pressure in the pulmonary artery.
Oh, you mean the CardioMEMS device?
Yeah.
That's a cool one. It's constantly checking the pressure in the artery that carries blood from the heart to the lungs.
It's like having a little guardian angel watching over your heart.
Pretty much. And this constant monitoring lets doctors adjust medications, especially diuretics, based on what's happening in real time, instead of waiting for symptoms to get worse.
That sounds super helpful. What does the research say about it?
Well, the Champion trial showed that CardioMEMS did reduce heart failure hospitalizations and improved quality of life. But another trial, Guide HF, didn't show a decrease in hospitalizations.
So mixed results.
Yeah. But then a later trial, Monitor HH, did show positive results for both how patients felt and dehospitalizations. Overall, a meta-analysis of all 3 trials estimated a 30% reduction in heart failure hospitalizations with this type of monitoring.
So it seems like it depends on how the information from the device is used.
Definitely. It's not enough to just have the device. You need to actually use the data to make treatment decisions, and you need good follow-up to make sure any problems are caught quickly.
It's all about using technology in the best way possible. Now let's talk about 2 more established therapies: implantable cardioverter defibrillators, or ICDs, and cardiac resynchronization therapy, or CRT. I know they've been around for a while, but they're still really important for managing HFrEF.
Absolutely. ICDs are like little watchdogs for the heart. They're always checking the rhythm, and if there's a dangerous arrhythmia, they deliver a shock.
So they're there to prevent sudden cardiac death.
Exactly. And CRT helps to coordinate the heart's contractions so it can pump more effectively.
It's like a pacemaker, but for the whole ventricle.
Right. But while many trials have shown that ICDs can help people live longer, the Danish trial, which looked at people with non-ischemic cardiomyopathy, didn't find that they reduced overall mortality.
So do ICDs not work for everyone with HFrEF?
It's not that simple. The Danish trial suggests that ICDs might be more helpful for certain groups, like younger patients, or those with ischemic cardiomyopathy. It all comes back to personalized medicine, figuring out who will actually benefit.
So it's about weighing the pros and cons for each person. What about advancements in CRT?
So traditionally, CRT uses a device that paces both ventricles, but there's a new approach called conduction system pacing that's showing promise.
Right, that one paces specific parts of the heart's electrical system, like his bundle or left bundle branch.
Exactly. Small studies have shown that it might be just as good as traditional CRT, but we need more research.
It's exciting to see new technologies like this. Now let's talk about another problem that can complicate HFrEF. Secondary mitral regurgitation.
Yes. This is when the mitral valve, that's the one between the left atrium and left ventricle, doesn't close properly, so blood leaks backwards.
Like a leaky faucet in the heart.
Pretty much. It makes the heart less efficient. And while this often gets better with medication and the heart getting stronger, some people need a more invasive approach.
And that's where transcatheter edge-to-edge repair, or TEER, comes in.
Exactly. TEER is a minimally invasive procedure. It uses a clip to fix the mitral valve. There were two big trials, COAP and MITRA-FR. They looked at how well TEER worked for secondary mitral regurgitation in HFrEF, but they had different results.
One showed a benefit and the other didn't.
Yeah. The COAP trial showed big reductions in heart failure hospitalizations and deaths, but the MITRA-FR trial didn't show any significant benefit.
So why the difference?
The article has some ideas. One theory is that people with something called disproportionate mitral regurgitation, meaning the light is more severe compared to their heart size, might get more benefit from TEER.
So it's not just about fixing the leak, it's about understanding how the lead affects the whole heart.
Right. Another thought is that the MITRA-FR trial didn't make patients be on the best medical therapy before the procedure, which could have changed the results.
It reminds us that medications are the foundation of heart failure treatment.
Yes, and procedures should be seen as adding to good medical care, not replacing it.
Now let's talk about revascularization procedures, like coronary artery bypass grafting, or CABG, and percutaneous coronary intervention, or PCI. These procedures are meant to improve blood flow to the heart. What does the article say about how helpful they are for HFrEF?
So the benefits of revascularization in HFrEF aren't as clear as they are for other heart problems. The early trials that showed CABG was helpful often didn't include people with really low ejection fractions. Plus, HFrEF medications have gotten so much better that revascularization might not add as much benefit as it used to.
So it's a tough decision, weighing the potential benefits against the risks of the procedure and also considering how effective medications are these days.
Yeah, right. The ACC trial looked at this. It found that CABG didn't reduce overall mortality in people with HFrEF, but it did improve the combined outcome of death from heart problems or needing to be hospitalized for heart failure.
So it might be helpful in some cases.
Exactly. And the REVIVE trial looked at PCI. It didn't find any benefit for people with HFrEF and a lot of coronary artery disease as far as mortality or hospital admissions went.
So the evidence for revascularization in HFrEF is complicated, and it's a decision that needs to be made carefully. Now, what about when heart failure gets worse, even with the best medical treatment?
When that happens. Getting to a specialist quickly is really important. The article has a helpful acronym, I need help. It lists the things that should make you think about sending someone to a specialist.
That's great. I'll have to remember that. So what are the treatment options for advanced heart failure?
One option is a left ventricular assist device, or LVAD. It's a pump that's implanted in the body, and it helps the weakened heart to pump the blood better.
So it's basically a mechanical heart.
Pretty much. And the good news is that outcomes with LVADs have gotten a lot better recently. The newer ones have fewer complications.
That's good to hear. And then there's heart transplantation. That's kind of the ultimate treatment for end-stage heart failure.
It is. Heart transplants are still the best option for people with advanced heart failure. If they're eligible, of course.
It's a big surgery.
Yeah.
But it gives people a chance at a new life.
And survival rates after transplants have also improved a lot. The average person now lives for more than 12 years after a transplant.
That's amazing.
Right.
It's a testament to how skilled transplant teams are. Now let's step back from all the high-tech stuff and talk about some non-drug, non-device treatments.
Good idea.
These are the lifestyle changes and other things that can help, along with medication. Let's start with the classic sodium and fluid restriction. I know that's been the standard advice for heart failure for ages, but I've heard that things are changing. What does the article say?
It's interesting. They're not as strict about it as they used to be. The sodium HF trial, for example, found that a low-sodium diet didn't really reduce the risk of heart problems compared to just eating normally.
So it's still good to limit sodium, but maybe not as much as we used to think.
Right. And if you restrict sodium too much, it can actually be bad. You might not get enough nutrients. Or it could even make your heart failure worse by messing with your hormones.
So it's all about balance.
Exactly. And we're seeing the same thing with fluid restriction. A big analysis of a lot of trials found that drinking more fluids didn't increase the risk of heart failure problems.
Well, maybe we don't.
Need to be so strict about fluid intake either.
Interesting.
Yeah, the thinking is changing. Doctors are now more likely to give individual fluid recommendations based on the patient's situation.
So personalized care is key. Now let's talk about cardiac rehabilitation. We know it involves exercise, education, and support. But how much does it actually help people with heart failure?
Cardiac rehab is actually really beneficial for people with heart failure. The REHAB-HF trial, which the article mentions, showed that it improved physical function in older patients hospitalized with heart failure. And it didn't matter what their ejection fraction was.
So it helps a lot of different people.
Exactly. And a meta-analysis of 13 trials confirmed those findings. They found improvements in both exercise capacity and quality of life in people with heart failure who did cardiac rehab.
So it really does make a difference. It's important to stay active and involved, even with a heart condition.
Absolutely. Cardiac rehab helps people take control of their health, and it also helps them connect with others.
It's about more than just the physical benefits. Now let's talk about something that's often overlooked: measuring patient-reported outcomes.
Ah, yes. This is all about going beyond the numbers, beyond blood pressure and ejection fraction, and asking patients how they're feeling, how heart failure is affecting their lives.
Because two people with the same diagnosis can have completely different experiences.
Exactly. The article talks about two questionnaires that are used a lot: the Kansas City Cardiomyopathy Questionnaire, or KCCQ, and the Minnesota Living with Heart Failure Questionnaire.
So these questionnaires give doctors a more complete picture of the patient's condition.
They do, and it's interesting, a lot of therapies have actually been shown to improve quality of life based on these patient-reported outcomes.
So it's not just about living longer.
Right, it's about living better.
Absolutely. But the article also mentions that there's often a gap between how patients say they're feeling and how their doctors think they're doing.
Unfortunately, that's true. A patient might be having a lot of symptoms, but their clinical measurements look fine, and what's even more worrisome is that these patient-reported outcomes can actually predict things like future hospitalizations and even death.
Wow, so these questionnaires aren't just a nice thing to do.
No.
They give valuable information
Right.
that can help make treatment decisions and potentially save lives.
Exactly. The authors say that we should be asking these questions routinely. They think it can improve communication between doctors and patients and lead to better decisions.
So it's about giving patients a voice.
Yes.
And letting them be a part of their care. Now, let's talk about something that's a bit uncomfortable, but really important: equity in heart failure care.
That's a crucial issue.
It means recognizing that not everyone has the same access to good health care or gets the same results.
Right. The article talks about the disparities in heart failure outcomes across different racial and ethnic groups. And it's clear that things like poverty, access to healthy food, and where you live play a big role.
These are the social determinants of health.
Exactly.
They have a huge impact on heart health.
And we need to do something about them.
The authors talk about the importance of raising awareness and advocating for equal access to care and making sure that clinical trials include people from all backgrounds.
Absolutely.
It's about making sure that everyone has a fair chance at good heart health. Now, as we start wrapping up our deep dive, let's look at the current guidelines for heart failure management and some of the new treatments that are coming out. We've covered so much today. It's exciting to see all the progress being made in both preventing and treating heart failure.
It really is. There's been so much research and innovation.
The article talks about the guidelines that were just published by the European Society of Cardiology, or ESC, and the American College of Cardiology, American Heart Association, and Heart Failure Society of America, or ATAH for short. These guidelines are basically the rule books for diagnosing and managing heart failure.
Right.
What do they say?
Well, the good news is that there's a lot of agreement between the two sets of guidelines. It shows that there's a global consensus on how to care for heart failure patients.
That's reassuring. So what are the main points of these guidelines?
Both of them emphasize those 4 pillars of HFrEF therapy we talked about. ARNI, beta blockers, MRAs, and SGLT2 inhibitors. And they stress how important it is to start these medications quickly and get the dose right.
So those 4 pillars are the foundation of HFrEF treatment.
Exactly. And for HFmEF and HFpEF, SGLT2 inhibitors are now considered first-line therapy too.
Those SGLT2 inhibitors are really making a difference. But what about the future? Are there any exciting new treatments on the horizon?
Oh, absolutely. One that's really promising is omecamtiv mecarbil. It works in a very unique way. It actually activates a protein that's essential for heart muscle contraction.
So it's like giving the heart muscle a power boost.
Exactly. The GALACTIC-HF trial showed that omecamtiv mecarbil reduced the risk of heart problems, especially in patients with more severe heart failure. But it's not available yet. The FDA didn't approve it.
So it's promising, but we have to wait a little longer. What other new medications are being researched?
Well, there's finerenone. It's shown great results for both the kidneys and the heart, especially for people with diabetes and chronic kidney disease. And then there's tirzepatide. That's another GLP-1RA, like semaglutide. It's being studied for HFpEF and obesity.
So many exciting possibilities. But let's go back to the basics for a minute. We talked about sodium and fluid restriction. Are those recommendations as strict as they used to be?
Not really. The article mentions the sodium HF trial again. They found that a super low sodium diet didn't really make a difference compared to eating normally.
So maybe it's more about moderation than avoiding sodium completely.
That seems to be the case. And some experts think that restricting sodium too much can actually be harmful.
Interesting.
Yeah, it can mess with your nutrition, and it can even worsen heart failure by affecting your hormones.
So it's all about finding the right balance. What about fluid restriction?
The research on that is changing too. The current thinking is to give personalized fluid recommendations.
Based on the individual patient.
Exactly.
It makes sense to take a more personalized approach.
Yeah.
Now, what about cardiac rehabilitation? How much does that help people with heart failure?
Cardiac rehab is really beneficial. The Rehab-HF trial showed that it improved physical function in older patients, regardless of their ejection fraction.
That's great to hear.
And a meta-analysis of 13 trials found the same thing. Cardiac rehab helps with exercise capacity and quality of life.
It's a reminder that staying active is important.
Yes.
Even with a heart condition. Now, let's talk about something we mentioned earlier, measuring patient-reported outcomes.
Right. That's about understanding how heart failure is affecting the person's life beyond just looking at medical tests.
2 people with the same diagnosis can have very different experiences.
Exactly. The article talks about the Kansas City Cardiomyopathy Questionnaire, or KCCQ, and the Minnesota Living with Heart Failure Questionnaire. These are used to assess patient-reported outcomes.
So they give a more complete picture of how the patient is doing.
Yes, and what's interesting is that a lot of treatments have been shown to improve quality of life when you look at these patient-reported outcomes.
So it's about more than just survival.
Right.
It's about how well you're living.
Exactly.
But the article also says that there can be a difference between how the patient feels and what the doctor sees in their medical tests.
Yeah, that's true. And even more importantly, these patient-reported outcomes can actually predict future hospitalizations and even death.
Wow, so they're really important.
They are.
They're not just about how the patient feels.
Right.
They can give us real information to help make treatment decisions.
The authors really believe in asking these questions regularly. It can improve communication and lead to better decisions.
It's about giving patients a voice in their care. Now let's talk about equity in heart failure care. This is about recognizing that not everyone has the same opportunities for good health.
Exactly.
The article mentions the disparities in outcomes across different racial and ethnic groups.
Yes.
And those social determinants of health are a big part of that.
Right. Things like poverty, access to food, housing, they all affect heart health.
We need to work on fixing those problems.
Absolutely.
The authors call for more awareness and advocacy to make sure everyone has access to quality care.
For sure.
And that clinical trials include people from all backgrounds so that everyone has a chance at a healthy heart.
Now, as we finish up this deep dive, let's talk about the big picture. All the progress that's being made in heart failure.
We've learned about new medications, advanced devices, lifestyle changes, and the importance of listening to patients.
It's an exciting time.
Big thanks to London Heartbeat Z Academy for giving us this incredible article, Advances in Management of Heart Failure, by Paul Heidenreich and Alexander Sandu. It's given us so much to think about.
It really has.
So, to sum up, we now have those 4 pillars of therapy for HFrEF. We know SGLT2 inhibitors are helpful for all types of heart failure, and we're starting to understand the importance of personalized medicine.
We've also seen how technology is changing everything, with devices that monitor the heart and new procedures.
And we can't forget about lifestyle changes, like cardiac rehab.
Right.
But maybe the most important thing is that we're starting to focus more on the patient,
Definitely.
listening to them, respecting their experiences, and giving them a say in their treatment.
It's about treating the whole person.
Exactly. With all these advancements, the future of heart failure looks brighter.
It does.
But we all have to do our part.
Researchers, doctors, policymakers, and patients.
We need to work together to prevent heart failure, improve access to care, and keep pushing for new discoveries.
Absolutely.
So as we wrap up this deep dive, I want to leave you with a question. What can you do to help fight heart failure? Maybe it's making healthy changes in your own life. Maybe it's supporting research. Or maybe it's speaking up for better healthcare policies. Whatever it is, we all have the power to make a difference. Thanks for joining us today. Until next time, stay heart healthy. This is such an important conversation. We need to do better. We need to make sure everyone has a fair chance at a healthy life.
Absolutely. The article talks about this a lot, the differences in heart failure outcomes.
Yeah.
Based on race and ethnicity.
Yeah, it's not right.
It's not. And it all comes down to those social determinants of health. Poverty, access to healthy food, housing, even environmental risks.
Things that are completely out of a person's control.
Exactly. And those things are the root of the problem. We have to fix those if we want to improve heart health for everyone.
Well said. The authors really emphasize the need for awareness and advocacy to fight those inequalities. Right. And make sure everyone has access to good care.
It's also important to make sure everyone is represented in research, in clinical trials.
Absolutely. We need to create a healthcare system that's fair and just for everyone.
I agree.
Well, we've covered a lot of ground today. From new medications and devices to lifestyle changes in patient-centered care, it's been a fascinating look at the world of heart failure.
It really has.
And I'm really encouraged by all the progress being made.
Me too. It's amazing to see how far we've come.
Before we sign off, I want to say a big thank you to London Heartbeat Z Academy for sharing this article with us. Advances in Management of Heart Failure by Paul Heidenreich and Alexander Sandu. It's been an eye-opening deep dive.
Huge thanks to them. They're doing such important work.
So just to recap some of the key points we discussed.
Yeah.
We now have those 4 pillars of therapy for HFrEF. We know that SGLT2 inhibitors are making a huge difference for all types of heart failure. And we're learning more and more about the importance of personalized medicine.
And we've seen how technology is changing the game with those new devices and procedures.
And let's not forget about the simple things, like cardiac rehab. That can make a real difference in people's lives.
Definitely.
But maybe the most important takeaway is the shift towards truly patient-centered care.
Yes.
Really listening to patients and understanding their experiences and giving them a say in their own treatment.
That's the future of healthcare.
Exactly. And with all these advancements, I think the future of heart failure care is looking pretty bright.
I agree.
It is. But we all have to play our part.
We do.
Researchers, doctors, policymakers, and most importantly, patients themselves.
It's a team effort.
We need to keep working together to prevent heart failure, improve access to care, and advocate for continued research and innovation. So as we wrap up this deep dive, I want to leave you with a challenge. What can you do in your own way to help fight heart failure? Maybe it's making healthier choices for yourself, or supporting heart failure research, or maybe it's speaking up and advocating for better policies. We all have the power to make a difference. Thanks for joining us on this journey, and until next time, stay heart healthy.